Thank you. Hello, everyone. First, I would like to thank the organizers for this opportunity. Today, I'm going to talk about the impact of chemotherapy on the genome of patients of childhood cancer and how the scars they leave on the genome could be used as markers of resistance to those therapies. Pediatric cancers, like around each year, around 300,000 children are diagnosed with pediatric cancer. Most of those are rare diseases, considered rare diseases compared to adult cancer. But still, they are the number one, collectively one, cause of death in many parts of the world for children. Most of the therapies are adopted from adult cancer, and most of them have developed or approved decades ago. But they work. And many of the 80 to 90% of children survive, but unfortunately, 2/3 of those survivors come back with a chronic health condition. One of those chronic health conditions are advanced tumors. Second, tumors are relapses, metastases, or secondary malignancies. They are usually resistant to therapy, and so the solution is to intensify therapy by giving them more different drugs, more cycles, and higher doses. Unfortunately, the survival rates drops from 80 and 90% to 10% for these patients because the tumors are resistant. So the study that I've done here is to learn the impact of therapy on the genome, what these therapies cause on the genome that create these secondary malignancies that are so advanced and so aggressive, and use that to devise more efficient and less damaging treatments. To do that, we collected a huge cohort of 611 samples. Huge, the number might not seem huge, but given that most of these patients are post-therapy, most of these patients are advanced, very aggressive tumors, this is a one-of-a-kind, almost one-of-a-kind cohort that collected from KICS, where I work at SickKids Hospital in Toronto, and Zero Childhood Cancer from Sydney, Australia, and Memorial Sloan Kettering. To show you how the therapy was used in these patients, you can see that around 24% of the patients received at least one therapeutic agent, and around 50% of them, it's difficult to see on the screen, got 1 to 4, and some of the patients got up to 16 therapies. So they leave scars on the genome, and some of these therapies are genotoxic. Not all of them cause damages and mutations on the genome. One of the ways to detect these damages are through mutational signatures. I'm not going to go into details of that, but most of these are hosted on Cosmic. Most mutagenic processes leave some unique patterns that we can detect and associate with those processes. Some of these processes are therapies, basically. Exogenous therapies could cause those, leave some scars, leave some mutations in the specific patterns that we can detect. In our data set, we found these mutation signatures on the x-axis with different etiologies. Some of them are novels that we discovered in our analysis. I'm not going to go through all of them. I'm more specifically going to talk about platinums here in this short talk. So platinum, 30% of our patients got platinum almost. And 50% of those platinum, we can detect the signatures of therapy, like the damage that therapy caused on the genomes. To see when we can actually detect these signatures, we discovered that in our cohort, around 90 days after start of exposure to therapy, to platinum therapy, we are able to detect the signatures. The pink ones are those samples that we detected the signatures in. The blue ones are not. So it's not 100%. It depends on tissue type and all other functions that I don't have time to talk about, but majority of them, after 3 months post-exposure, we can detect the signature. And looking at the accumulation of the signature in the cohort, we see that around 12 months, 35% of the patients show the signature, and within a year and a half, almost half of those patients, we are able to detect the signatures of therapy in them. So the goal is to use these as a marker of resistance. So to basically, if we can detect the signature of platinum therapy, can it be used to predict if those samples going to be resistant to further therapy, to platinum therapy in future? And to do that, we did look at the RNA-seq data. We compared the signature positive samples with control, signature positive versus signature negative ones, and signature negative ones versus control. We found two, it's pretty small, but two genes, GSDA1 and ABCC2, that were upregulated in signature positive ones compared to the other two. And which is to show you how important they are in the resistance to platinum. You can see that when platinum enters the cell, GSDA1 attaches the GSH glutathione to it and creates this platinum GSH conjugate. Then ABCC2 detects this and basically sends excreted out of the cell. And this way they created therapy resistance. So we showed that the samples that have the genomic signatures also have an active upregulated genes involved in platinum detoxification. So this genes, the samples with the signatures could be used as markers of resistance. And yeah, so basically that's the point that I'm making here. And with that, thank you everyone. I'm Schlein Lab, I'm a senior research associate at, and the Alexandrov Lab, and the cohorts that we got from sick kids, zero childhood cancer, and MSK. And thank you guys.
We have time for questions.
Hi, thank you so much for right here. Thank you so much for a very interesting talk. I had a couple questions. So the first is, what kind of sequencing data are you using to extract and assign these signatures?
WGS, whole genome sequencing.
Okay, sounds good. And then secondly, do you have any thoughts on whether the effects of chemotherapy should be different in children that have these secondary cancers versus in adult data sets? Do you expect to find similar patterns or different ones?
So there are some that we find that are specific to children because of the developmental stage and the metabolism and the genomes and also the age of the patients, how much somatic, because these are somatic mutations, right? In adult cancer, they had a lifetime, like 70, 80 years, accumulated a lot of those mutations, somatic mutations that are from different mutagenic processes. In children, we have fewer, quieter genomes with fewer mutations. So, and those are some of them are unique to, childhood cancers, but the therapy, the mechanism of action of the therapy is the most important factor. And platinum, we expect that platinum to cause the same damage in children compared to adults, but it could be at different level. We think that we detect them more, so they are more damaging in children than in adults. So it's easier to detect that.
Okay, thank you so much.
No worries.
I'm very sorry, we have to move on, but you might be able to ask the question directly after, right? So thank you very much for your presentation.
Thank you, everyone.